Well, thank you very much, everyone. And I'd like to congratulate Beth, Antoinette, and the entire team. I mean, I think this is an incredible educational event for all of you, all of us, and I think it's great. Great job. But I want to just talk to you a little bit on PAD, and I want to really break it down where I know a lot of you are taking care of patients with PAD, but maybe not participating in the cases. But it's important for you always to keep updated, and conferences like this help us to do that. So let me just get right into it. So these are my disclosures. So now, remember, when you talk about peripheral vascular disease, the most common thing that you're going to be treating is intermittent claudication. So intermittent claudication, obviously, is supply doesn't equal demand. So when a patient walks, classically, they're going to get calf claudication because there's not enough blood to supply the calf. So when we do endovascular treatment of this, all we're trying to do is achieve straight line flow into the muscle so that the patient is able to walk. So generally speaking, I guess this is it. Okay, so we have all these tools, okay, and all of you work in the cath lab, I'm assuming, or taking care of cardiac patients. So you have angioplasty, stenting, atherectomy. We use directional atherectomy with the Silverhawk, or laser, or specialized angioplasty devices. So you have multiple different tools, but in reality, up to now, all of this has just been tools in a toolbox. So all we've been able to do is achieve, straight line flow, but we've failed in keeping these arteries open for a long period of time. So there's a little bit of evolution that I want to go over. So as you know, everybody knows this is balloon angioplasty. But in the legs, balloon angioplasty was what we started with because pretty much we translated what we did in the coronaries into the legs. But however, in the legs, it doesn't work. Now, how doesn't it work? Let's think about it this way. It depends on what you're doing balloon angioplasty for. So for instance, even in the heart, balloon angioplasty doesn't work in terms of long-term patency. However, if you're doing balloon angioplasty for an MI, you are going to acutely open the vessel. You might struggle to keep it open, but you're going to open the vessel and save myocardium. So in the legs too, if you do it for critical limb ischemia, and this is Dr. Graziani's data from Italy, who's here with us in the endovascular course, you see that he's able to achieve 99% technical success rate, but if you look at the 5-year assisted patency rate, meaning that you have to do repeat procedures to keep this open. Okay? So why does balloon angioplasty fail? Well, there's two things. When you do a balloon, you cause injury. When you cause injury, you initiate a cascade of events that's going to cause scar tissue formation or restenosis. So the second one is that the vessel may recoil. So initially, just like the coronaries, we said, hey, let's put a stent. But guess what? Stents work, but it depends on where they work. And I want to give you a take-home point, okay? So whenever you think of endovascular stenting, I want you to think about 4 things. Actually, 3 things. 1, where's the location of the stent? 2, what is the length of the stent? And 3, whether it's a stenosis or an occlusion. So this crazy slide here, all it's telling you is the larger vessels like the iliacs have better patency than the smaller vessels like the SFAs, have better patency than the really small vessels like the tibials. So longer lesions have worse patency than shorter lesions, and occlusions have worse patency than stenosis. Simple, okay? But so what happened with stents was the same thing that happened in the coronaries, is that yes, you were able to prop the vessel open, but you were unable to stop the restenotic reaction initiated by the initial balloon injury that you used. So then, pretty much similar to the coronaries, as you see, we were kind of playing follow the leader, right? Although we're starting to lead in a few things now. But you can see here that what we said was, hey, they really figured out how to tackle restenosis in the coronaries. The entire sirolimus project was really initiated at Sinai, although we didn't put it together, but clearly the initial work was done here. But so what we did was basically took the same proof of concept, saying if there's an aggressive proliferation of cells causing restenosis, what works against that aggressive proliferation of cells? That's going to be anti-cancer drugs. So they chose Paclitaxel, and they wanted to do a proof of concept trial. So they said, hey, can we inject it into the contrast? Or do we have to put it on the balloon and actually deliver it to the tissue wall? So this is the Thunder trial. As you can see, that they had three arms. One was a conventional balloon, which is your control arm. Then they did conventional balloon coated with Paclitaxel in contrast. Excuse me, conventional balloon with Paclitaxel injected in contrast. And third is the coated balloon. And what they found was basically it works. Okay, so this created the excitement in the peripheral vascular market, because what happens is our patients have a high restenosis rate. I don't know how many of you were in the coronary world back in the day when a 2.5 millimeter lesion in a diabetic would have about a 40 to 50% restenosis rate, pretty much come back every 6 months. We had to do brachytherapy, so on and so forth. So this was really exciting stuff, that you can actually reduce the binary restenosis rate not only at 6 months, 12 months, and 24 months, okay? And also in long-term follow-up, also if you look at TLR, which is target lesion revascularization, it's also reduced. So bottom line, you do a procedure, you use a drug, the patient doesn't come back, or actually doesn't come back more often than they used to. So which is great. So you actually are making the patient feel better and giving them durable therapy. Now, everybody knows what is DES. Like, what is a drug-eluting balloon, okay? So the DES is basically slow release with persistent drug exposure, forget the dose, and DEB is short drug release and a short exposure. So remember, in DES you have an elution, right? In DEB you have a delivery. Okay, so that's the difference. So whenever it says to you, when somebody says to you, well, it's a DES I'm putting in the leg, well, they're not really putting a DES. They're really, if they use a balloon, they're using a DEB, okay? So why Paclitaxel? That's another question, because in coronary we have the Zion stents, and we have obviously the Paclitaxel stents, and then we have this, all these zotorolimus stents. But why did we choose Paclitaxel in the peripheral? Well, it's an antiproliferative drug. It's lipophilic, right? It's normally used at doses. Anyway, we're going to skip this part here. So anyway, it blocks proper microtubule formation and inhibits cell division and migration. Okay, and basically it does not inhibit endothelial cells. So what this is basic picture of how they coat the balloon, right? It's basically a spacer. They use a spacer with a high contact surface between the lipophilic drug and the molecules and the vessel wall, which delivers the drug to the vessel wall. Oops, I'm sorry about that. And this is a classic example of one that was done, a long time ago in Germany. And you can see here an occluded vessel. Here's a paclitaxel-coated balloon going up. Here's actual dissection, remodeling, and healing of the vessel. So you're talking about pretty much, all the way from 2004 to 2006. And I know all our nurses who work in the cath lab will tell you that if we get things like this, we're thrilled. And unfortunately, it's not often that we get to see 3-year patencies like this. So what's out there? What can you expect in your practices, right? That's what I want to really go over. Well, you have there's a revolution occurring. Honestly, it's in PAD. So you have a lot of companies getting into the drug-eluting balloon technology and are very excited. So you have the impact balloons, which they just completed their randomized trial, which is by Medtronic, which again uses paclitaxel. I'm just going to concentrate on what's in America right now. And the Moxie balloon, which is a Bard balloon, which is owned by Bard, which also completed their trials. Both these, actually, Moxie is actually presented to the FDA, and they're submitted for publication, as has Impact. So therefore, these balloons are going to be in your hands and in your labs, and you're going to be taking care of patients who receive these balloons very, very soon. Now, this is just some little clinical data, and this is with the Moxie balloon Levant trial, just to let you know. So this is what we did. So basically, it was basically you have a predilatation of a lesion, and if you have a suboptimal PTA or major flow-limiting dissection or greater than 70% residual stenosis, you're going to treat per standard practice. If you have a successful predilatation, then you're going to randomize 2-to-1 to the test with dilatation with the drug-coated balloon versus control, which is the plain balloon. 12-month follow-up. And what they found was they basically reduced the composite safety. It was a safe drug to use. Second, they also had an increased primary patency compared to regular balloon. And they also had freedom from TLR. Exciting stuff. Because when this disease is very, very prevalent and is very, very symptomatic for these patients. So then the other thought was, well, we have a stent. Why can't we put it in a stent? So there is a drug-coated stent that's available in the market now, and it's made by Cook Medical, and it's called the Zilver stent. So the drug-coated stent, I say, is drug-coated, not drug-eluting, because it does not have a polymer. So remember, it doesn't elute over a period of time. It's basically a coating on the stent that's placed in, and then it basically delivers the drug. So again, just for the sake of time and really just keep it simple, what we wanted to do was we basically compared it against PTA, okay, and how it was done was basically 1-to-1, and if they failed PTA, they had a bare metal arm, which is beyond the talk. But the bottom line is you had an increase in primary patency of the drug-coated stent versus POBA, and even versus bare metal stent. So now you're actually giving your patient lots of options. So in a sense, in the past, there was a big trend against doing angioplasty repeatedly, and rightfully so. You had increased exposure to contrast, increased exposure to radiation, obviously, and the complications associated with that, such as kidney toxicity, the risk of dialysis, and radiation exposure. But now you have the option, which is going to be available very soon, and one of them already is, to be able to give another option to your patient to make them feel better. One thing I want to tell you, so you could say to me, well, what about drug-coated balloon versus drug-coated stent, right? So right now we don't have any trial because we don't have a approved drug-coated balloon. Once we have an approved drug-coated balloon, those trials will occur. Second, I want you also to think about this. You should say to yourself, well, Prakash, what did they study in the trials, right? You're telling me that longer lesions do worse than short lesions. You're telling me that tibial lesions are worse than SFA lesions and worse than iliac lesions. Well, guys, these are all SFA trials of moderate length. Okay? So you're talking, what do I mean by moderate? In the peripheral world, 60 to 80 millimeters is considered relatively short. In the SFA, we routinely do 250, 300 millimeter interventions. Okay, in the coronaries, 38 millimeters is big, right? So the point is, we're talking about a different ballgame. So yes, that's a good question. We don't know how this is going to do against a very complex real world. There are registries, but registries don't really speak of true science, do they? I mean, they're telling you kind of a trend and kind of thought-provoking. But clearly, we don't have an answer. Well, will these work in long lesions? So in conclusion, very, very simple. Paclitaxel is the active drug component of all DEB products so far studied. Okay, numerous clinical trials are on their way to evaluate the performance of DEB in different peripheral indications. Thank you very much for your time. Thank you. Okay, so I've got 2 questions here. So again, I want take-home points, so my questions are very take-home. Randomized controlled trials show that DCB versus primary PTA, A, increases restenosis rate, B, has a similar rate of restenosis, and C, decreases restenosis rate. Everybody better get this right. Yes, well, who's the 6%? Come on, guys. All right, this one better be 100%, okay? All right. Ready? The drug used in current DCB trials is paclitaxel, sirolimus, and tacrolimus. I know, I'll tell you. You guys know how to keep a guy down, Thank you. Thank you very much.